Good afternoon, everyone. We're just letting folks come into the waiting room and we'll get started. Okay, good afternoon, everyone. My name is Paul Bittinger. I am the medical director and lead for the Region 1 Regional Disaster Health Response System that is funded by the Administration for Strategic Preparedness and Response within the United States Department of Health and Human Services. We are really pleased to be able to present to you an additional lecture within our series focused on the pediatric surge that we've been experiencing over the last couple of months. And we really have, I think, a very, very helpful and timely topic for all of you on the interim management of the pediatric patient with respiratory illness who's awaiting transfer. Unfortunately, we've probably all experienced the fact that sometimes it's really hard to identify an appropriate receiving bed, whether inpatient pediatric or inpatient ICU pediatric bed. And that means that a lot of emergency departments have needed to care for sick kids longer than they traditionally would if they're not part of pediatric hospitals. So we have an extraordinary group of speakers and a lot of really, really great content. So we're very, very grateful to be able to present this session to you. As a reminder, all of these sessions are archived. And so if you want others to hear the content that you'll hear today, please do ask them to visit our website, rdhrs.org. This session shortly this afternoon after we're done will be posted there. Next slide, please. So as I mentioned, we're really, really fortunate to have an extraordinary group of speakers here who have a variety of perspectives that I think will be very, very relevant to what we're talking about. We have Dr. Karen Gruskin, who is from Boston Children's Hospital and Beverly Hospital. I'm not going to read everyone's titles just because I want to get us deeply into the content quickly. But we have Jessica Sexton, we have Dr. Laura Bately, Dr. Asina Exafaris, Jesslyn Lennis, excuse me, and Amanda Wentworth-Giles. You can see phenomenal perspectives of nurses, respiratory therapists, physicians, both in community and in academic settings. And I think that really is exactly relevant to what we're talking about now. Next slide, please. So we do want to acknowledge the support of ASPR, again, the Administration for Strategic Preparedness and Response within the USHHS. Next slide. And just wanted to offer the disclosure, of course, that we have to offer, which is first off, the content here is the opinion and presentation content of the speakers, but does not represent the United States government. It is not medical advice and should not be used as a substitute for professional advice to diagnosis or treatment. None of this is legal advice, and none of the speakers have financial interests or conflicts of interest to disclose. So with that, I'm going to turn it over to Dr. Gruskin. And again, really, really so grateful for everyone's participation. Thank you all for joining us today and for everything you've been doing during this surge so far. Dr. Gruskin.
Thank you. In addition to the speakers that Paul so kindly introduced, I want to mention that we have additional partners on the call from our teams and would like to introduce Seth Kelly and Molly Swan, who are both clinical practice specialists, one from Beverly and one from Winchester Hospital. We have Monica Kleiman and Jordan Reddick, who are physician leaders in our ICU at BCH and oversee the communication center. And lastly, a big shout out to Alice Smith, who previously developed the high flow nasal cannula protocol and process for higher acuity patients with her team at South Shore, and is now full-time at the intermediate care program at Boston Children's and is on the receiving end of many of the transferred non-intubated patients. Before we go further, I do also just want to thank each and every one of you who is on the front line of providing clinical care. We thought the pandemic was challenging, and I think that this pediatric surge with a limit in all sorts of resources that we have previously been used to has been perhaps even more challenging. Please remember, in addition to taking care of your patients and families, to take care of yourselves and each other. kindness, especially during this time of stress, I think is really appreciated. For learning objectives, I have listed what we're hoping to go through. First, convincing you that you can do this, the importance of distinguishing stable distress from respiratory failure, reviewing common respiratory diagnoses and treatment pearls, which is perhaps a little bit of a review from previous information shared, but hopefully we'll pull things together as we share our network's pearls. Review some modes of respiratory support, when to use them and how to wean and escalate. Empowering and including families in care, as they're often overlooked as partners who can help ease some of the burden. How to mobilize hospital resources to best support these high acuity, low volume patients. And then how to identify and develop resources to provide pediatric care in the community setting. As hopefully you realized, all of us work in a community network hospital. Full disclosure, all of our community hospitals do have pediatric inpatient units. And so some of the information shared will be in that intersection between care that some of you might be needing to provide in the ED and some of the patients that we have been able to move to our floors, but we believe that the principles are the same, and we hope that they'll be helpful. I think of medicine as a team sport, zone defense in basketball. It takes a village, and the list of team members is long. And remember, among this team, you have the skill set to take care of the child with respiratory illness if you're used to taking care of kids in your ER. It's just, where are they on the spectrum as they're in your ER versus when they first get to your ER. And we hope that we'll share the resources deployed in new or innovative ways that we found that perhaps you can leverage to your needs. And we have found that the biggest difference is really in flow, not in knowledge, perhaps a little bit around the equipment needed or buffing up skill sets. I'm an ER doc. I tend to be very simplistic. There's very few graphs or formulas that I remember or know. This is one of the few of the graphs that I think is really important to think about, which is remembering that kids in respiratory distress who come in with O2 sats, maybe 88, 89, 92, are way on the flat side of this curve. And you have lots of time until you get to that red arrow, which is actually around 76%. And that's the beginning of when a child is going to acutely begin to decompensate. And the entire time that they're on that flat portion, you've got plenty of time to make interventions, to provide treatment, and to improve their work of breathing such that they never get to that orange arrow. And with that, I'd like to turn over the next section to Lara Beatty, who's going to provide a little more information about herself and then review causes and common treatment considerations. As Paul mentioned, please feel free to place questions in the chat, and certainly in real time if it's a clarifying question, and he'll make sure that the speaker is made aware. Lara?
Thank you so much, Karen. I'm very excited to be here as part of this group to speak with you today. So I'm a pediatric hospitalist working at South Shore Hospital currently within the Boston Children's Network. I've been in community medicine now for about 8 years, and prior to that had some experience as an ICU hospitalist at Boston Children's Hospital. So I've sort of had the viewpoint of both sending sick patients in and receiving them for care. For my segment of the piece, I hope to kind of pull together the previous topics that have been discussed in the prior sections and just sort of briefly review everything with an emphasis on slightly expanding the respiratory differential diagnosis from the prior sections, and then also discussing a little bit more about the ongoing treatment for patients that stay in your ER or hospital settings for longer than they have previously. So for this segment, I'm going to focus on sort of these four bolded respiratory illnesses. So bronchiolitis, I know you had a full hour dedicated to this topic. We'll briefly review that, but would also like to discuss the presentation and treatment for asthma or reactive airway disease, pneumonia, and croup. Down below, I have some of the less common causes that you can consider. And these are, this is certainly not an exhaustive list, but the top four are really crucial to think about. And it looks like the picture might not be advancing, but it's supposed to be a picture of there we go, a very cute toddler stacking some blocks, which is really just to remind us that some of these disease processes actually stack one on top of another, which some of us in pediatrics refer to as asmoniolitis. So sometimes you're dealing with more than one disease process at a time. Next slide, please. So to quickly review bronchiolitis, this is a viral infection of the lower airways, generally affecting children less than 2 years of age. Those that are at highest risk for decompensation are patients who are either preterm, neonates, or those with underlying immune or heart and lung disease. And there are many common viral causes that are known to result in bronchiolitis, with RSV being the most common. Next slide, please.
There we go. Sorry about that.
No problem. So signs and symptoms, I think we're all very familiar with all of these. Patients can present with cough, tachypnea, difficulty breathing. With bronchiolitis, we tend to think about more diffuse lung findings, which I've bolded here, often presenting with coarseness, crackles, and wheeze, which some of us think of as sounding almost like a busy washing machine. Next slide, please. So the treatment, both initial and ongoing for bronchiolitis, unfortunately, is supportive only, as we all know, and generally the mainstays of treatment are suctioning, hydration, and oxygen and/or respiratory support as needed. What I'd really like to emphasize here is the hydration piece. I think in my clinical practice with all patients who come in with respiratory distress, they are generally more dehydrated than we think they are, both because of ongoing insensible losses from fevers and tachypnea, but also from poor oral intake leading up to their hospital visit. And so while we know that it's challenging to place IVs sometimes in young infants, I encourage people to consider placement of NG tubes, particularly for bronchiolitis, to support hydration and nutrition, which we've been able to do successfully at our community site. Next slide, please. So getting into asthma and reactive airway disease, this represents the most common chronic illness in childhood, and it is a lower airway hyperreactivity process. Flares are triggered by many things, including upper respiratory infections, exercise, and environmental triggers. And the distress causes three primary problems that are then targeted by our treatments. So it causes bronchospasm, inflammation, and mucus plugging. Next slide, please. Again, similar signs and symptoms to the prior set we've looked at, but wheezing tends to be the hallmark feature of asthma, with the big caveat in red here that sometimes if a patient has a history of asthma, you're worried about reactive airway disease, you might not actually hear wheeze in the setting of a patient who's critically ill because of severe airflow restriction. So in that case, giving albuterol will paradoxically create a wheeze, and that's actually because you're aerating the patient better. So I would say just encouraging everybody, if you're thinking about asthma, to treat it and treat it aggressively. So the treatments, so I have in black sort of the initial treatments and in red the ongoing treatments. I think this is the one disease process we'll discuss where it's really important to stay on top of treatment and treat frequently. So most of us are used to treating in an ER setting an initial flare with a duo-neb, which contains both albuterol and ipratropium, and then giving some form of systemic steroid. Generally, most patients improve after that initial management, but for those that don't, we often progress to IV magnesium sulfate, which we give with a normal saline bolus to offset the risk of hypotension. And for patients that don't respond to that level of treatment, we then think about going to systemic beta agonist therapy like terbutaline, knowing that in some community ER settings, terbutaline might not be readily available or there may be less comfort with its use. So just to consider an EpiPen as a really quick alternative, which I've personally been able to use successfully in a few patients with really sick asthma. And then for the ongoing treatment, I think it's really important to not get behind with the albuterol management. So patients can receive the albuterol at least every 4 hours or more often, up to continuously. And in a busy ER, it's hard to sometimes keep track of where they are. So just keeping that on the radar to give them the frequent albuterol that they need. Ipratropium isn't often continued in sort of a moderate illness setting, but for patients who are sick enough to require IC level care, that can be continued at a Q6 hour interval. And then the systemic steroids are often also continued with a range of dosing and therapies, but generally at our site we'll redose 1 milligram per kilogram of methylpred or Orapred every 6 to 12 hours, depending on level of illness. And then with both the terbutaline and epinephrine, they can be given as an initial loading dose, but you're also able to provide them in drip form for patients who are critically ill. Next slide, please. And then pneumonia will be sort of the last lower respiratory illness we talk about. So this is inflammation of the pulmonary parenchyma. In pediatrics, this is often caused by viral or bacterial pathogens. In terms of the viruses we think about, it's the same group implicated in bronchiolitis, which makes distinguishing one from the other very challenging. There are several different bacterial etiologies to consider based on patient age group, but the most common bacteria that causes pneumonia across all pediatric age groups is strep pneumonia. And then if we can just go back 1 second, just in terms of getting a chest X-ray, we just encourage you to interpret with caution. So it's very rare that you get a beautifully clear right middle lobe pneumonia, as I have here in the X-ray in the picture. Very often you can either undercall or overcall pneumonia on a film. For patients early in disease or who are dehydrated, you might not see an infiltrate that's actually there. And for patients who have another process, such as bronchiolitis or asthma, you might see opacities that can be mistaken for multifocal pneumonia. Next slide, please. Again, very similar signs and symptoms to the previous illnesses, but what can distinguish pneumonia from the others would be focal crackles or asymmetric breath sounds. Next slide. And then the treatment here, as with the others, aggressive fluid hydration, oxygen and respiratory support as needed. And I think it's worth just taking a moment to discuss antibiotic selection, particularly as we think about antibiotic stewardship. Because strep pneumo is the most common bug that causes bacterial pneumonia in pediatric populations, for patients with an uncomplicated pneumonia, the appropriate choice of antibiotic is ampicillin. And that's dosed 50 milligrams per kilogram Q6 hours. So that's a treatment that may need to be repeated if you have patients staying in your hospital for an extended period of time awaiting transfer. And then for patients that are higher risk, so those that are less than 12 months who are or under vaccinated, who have severe illness, or those who failed outpatient treatment with antibiotics, ceftriaxone and other broad spectrum antibiotics would be appropriate. And then finally, we'll just touch base about croup. This is inflammation of the upper airway affecting the larynx and the subglottic region. It usually occurs in patients ages 6 months to 3 years, although outliers are definitely possible. This is also caused by the same bugs that cause bronchiolitis and viral pneumonia, but in this scenario, parainfluenza is the most common cause. I've also bolded COVID here as well, as that's been an evolving cause of croup in the pediatric population since the pandemic began. And then evaluation is actually most often clinical. If you do obtain a chest X-ray, you'd expect to see this steeple sign that you can see on the right here, which is narrowing of that subglottic region. But very often you're just going to diagnose and treat clinically, and the X-rays are generally reserved for patients where you're concerned for other etiologies. For a patient who has signs of upper airway distress, who has high fever or is toxic or ill appearing, you're going to be thinking about other etiologies such as epiglottitis, which has a very different treatment management algorithm. Next slide, please. And then for croup, again, similar symptoms to the prior, but stridor and a barking cough can sort of help you distinguish this from the other symptoms we've discussed, or the other processes we've discussed. And then in terms of treatment, generally is twofold with steroids. Dexamethasone is often dosed at 0.6 mg per kg every 24 hours, and that can be given PO, IV, or IM if a patient's unable to tolerate PO. And then racemic epinephrine In terms of indications to treat, there are different scoring tools. One of them is the Wesley score, which is a little complicated to look at. But as a general rule of thumb, if I have a patient who has stridor at rest, I'm going to treat them with racemic epinephrine. And then that can be repeated frequently. And the frequency with which you need to give the racemic epinephrine helps determine level of care. If a patient just receives a single racemic epinephrine in the ER and then looks great for the following 3 hours, they are generally considered safe for discharge versus a patient who might need a dose every 20 minutes or every hour, and that's going to be a patient who's going to need ICU level care. And lastly, with croup, you want to do your best to keep patients calm just because the agitation can increase the airflow restriction. And then regardless of the underlying etiology for the respiratory distress, I think the most important job that we're all tasked with in a community setting is to really figure out which are the kids that are sort of teetering on the edge of the cliff of respiratory failure. And so when I approach a patient, I sort of look at 3 big buckets, looking at both neurologic, respiratory, and circulatory status. And of those, I think that the neurologic piece can be the most informative. So if a patient is extremely irritable, extremely lethargic, or most importantly, becomes less responsive over time, I'm really worried that this patient is declining and needs significant escalation and support. From a respiratory standpoint, if there are severe retractions, poor aeration and grunting, or from a circulatory standpoint, if we've provided fluid resuscitation and we still have severe tachycardia without fever, delayed cap refill, or pallor and modeling, we think about escalating patients. And then some supplemental data that can help suggest severe illness would be those patients who are hypoxic despite providing low flow oxygen therapy, or those who have any CO2 retention on a blood gas, if that's available to you. Next slide, please. Perfect. So now just to quickly review the levels of escalation when we're providing additional respiratory support. This is to talk a little bit about high flow nasal cannula, and this pathway is compliments of Dr. Alice Smith from Boston Children's Hospital, who developed this and has shared this through the Mass Department of Public Health. This is just one of many really excellent high flow algorithms that are out there. I think in the prior lecture series, Yale has one that they've shared. They've reviewed one from the Children's Hospital of Philadelphia. Mass General Hospital for Children has one as well that's been shared. I think the big take-home message is that we encourage each hospital to at least adopt one of these so that they're taking a unified approach to how they address and manage these patients. And I think each of these algorithms, it's really important to emphasize not just the escalation pathway, but also when patients are eligible to wean. So in terms of quick key points, so providing high flow nasal cannula allows us to help patients with work of breathing by providing flow, and oxygenation by providing FiO2. In our algorithm, we start on 1 liter per kilo per minute, escalating to a maximum of 2 liters per kilo per minute. But again, there's variability depending on what you use. And it's important to try weaning as soon as you're safely able to do so. So we try weaning after 4 hours of stability, as long as there's a reasonably low FiO2, which we consider to be 30% or less. And then to decide when a patient's safe for discharge, we like to watch them for at least 8 to 12 hours off of high flow. And then the last pearl that we have from our clinical experience is that most critical care transport teams cannot transfer patients on high flow. So often they will have to be transitioned over to CPAP for safe transport. Next slide, please. And I know you had an entire hour dedicated to non-invasive positive pressure ventilation. I'm trying to sort of whittle it down to just one slide here, but just as a quick review, the 2 forms of non-invasive positive pressure ventilation are CPAP and BiPAP. With CPAP, you're able to set both a PEEP and an FiO2, which allows you to help with oxygenation and also helps patients with work of breathing. We commonly use it in cases with bronchiolitis when there's hypoxia and increased work of breathing that aren't well captured using high flow. And then with BiPAP, you get all the same benefits from CPAP, but you have the added benefit of adding a positive inspiratory pressure, a rate, and an I time, all of which allow you to support ventilation for patients. So the scenarios where we commonly use these would be with severe asthma, because it helps with ventilation, but also because with most setups, you can actually give albuterol in line. And it's also commonly used in cases of severe work of breathing and respiratory acidosis, again, because of the ventilation support. And in the bottom there, I just want to highlight that while giving any form of positive pressure, you are going to be increasing air in the abdomen, which has two major risks, one of which is the risk of increasing the possibility of vomiting and aspiration, and two, that sometimes when the abdomen becomes so distended, it can actually create abdominal competition for the lungs. And so important to consider placing an NG sump to decompress the belly. Next slide, please. And then intubation, this is sort of my last segment here, just to remind everybody that this is really a last resort in pediatrics, that children can tolerate respiratory distress while maintaining adequate gas exchange for a long period of time as compared with adults. If the patient is stable, and going back to Karen's curve, thinking about where they are on that curve, if you feel that you have some time, it's worth considering a PEDS ICU phone consult to discuss your plan for intubation. And then I just would reference last week's session on 12/7, which really was an excellent review of rapid sequence intubation and vent management strategies, just to review this concept further. And that's sort of the end of my segment here. We're very lucky at South Shore to have a really excellent team of pediatric respiratory therapists who help us manage a lot of our really sick patients. And I'd like to turn the conversation over to Jessalyn Lennox, who's the director of our respiratory program. Thank you.
Hi, thank you for having me here today with this great group of people. I'm just going to talk about some of the things that we do to manage our respiratory patients here at South Shore Hospital. We're fortunate enough to have all BCH docs and providers here to work with us, and we have a really collaborative relationship. And so we do have a lot of therapist-driven protocols here that I'm going to be sharing with you that hopefully alleviate some of the stress of having these patients that nowadays sometimes need to be kept a little bit longer than we might be comfortable with. We're fortunate to have been able to grow this program quite a bit, working closely, as Dr. Beatty had said, with Dr. Alice Smith before she went full-time into BCH, and developed some good protocols here. Here, I'd like to start with just some of the anatomical differences that really, I think, illustrate well the differences between adult and pediatric airways that can sometimes explain why they can become more of an emergency much more quickly than an adult, and vice versa. So one of the things that I think is important to start is the tongue is a lot larger in proportion to the mouth, which can, when they're having challenges orally, in addition to the nares, can make it a lot harder for them to breathe. As you can see, the pharynx is smaller, and the epiglottis is relatively a lot larger and floppier. So epiglottitis, that's how it becomes an emergency, and hopefully that's not something that we see very frequently. So the larynx is much more anterior and superior, as well as the airway being the narrowest at the cricoid. So, you know, one of the reasons for anyone who's familiar with pediatric ventilation, that's why we tend to not use cuffed ET tubes as frequently with pediatrics, because of that narrow airway there on the pediatric patient. And also the trachea is obviously a lot more narrow and less rigid. Next slide. So this is some of the information that we collect on any of our pediatric patients that come in. This is actually from our EPIC system that we document our hospital asthma severity score within EPIC. And so we'll get into that in a moment, but just to look at it, it's the same stuff that we look at all the time, right, when we're looking at these patients. So we're looking at their SATs, we're looking at listening to their breath sounds, we're looking at their work of breathing, their retractions, and their respiratory rate. One of the things that obviously is a little bit different with pediatric patients is that we want to take their age into consideration when we're looking at them. And so we do actually have this broken up in our EPIC system by age for appropriate ranges for each age group. But as you can see here with this SAT, one of the challenges with that might be that we want to make sure that we're doing that on room air so that we can see what their needs actually are. There can be a tendency to put them on oxygen right away, but it is great if you're able to look at that information prior to starting them on oxygen so we can see what their need actually is. We want to listen to their auscultation, listen to their breath sounds, and like Dr. Beatty said, sometimes the absence of wheeze can be comforting, but it can be scary at the same time. So we want to make sure that we're listening to their breath sounds and assessing them well to see at what part of their inspiratory versus expiratory phase that they're having difficulty. Looking at how many muscle groups that they were trying to use to be able to breathe, right? So we know with upper airway issues such as asthma, that it's the breathing out, the exhalation, that is causing the problem. So if they're using all of their muscles to get every breath out, or they get to the point where they're using a lot of muscles to breathe in and then need to then additionally use muscles to try to push the air out, because we know that the air is stuck down there and we're actively exhaling, we know that they're having distress, and that's what we want to try to relieve. And that's what we'll get into with all the treatment that we use for our HOS-based scoring system. Their respiratory effort. So a lot of times with kids, again, this is going to be age dependent. So we're going to see whether or not they speak in full sentences. Oftentimes when kids come into the emergency department, they don't want to speak to us, right? They're scared. They have a lot of strangers around them. But sometimes you can talk to them about their stuffed animal that they're holding, or you can ask them to sing their ABCs. Kids sometimes like to show off, even when they're not feeling well. So getting a little creative and getting them to speak and to see how well they do that, they're naturally going to compensate for what they're experiencing. So they might naturally start talking to you like this when they're trying to tell you their ABCs. That's telling you that they're speaking in partial sentences, right? So that's going to tell you that they're having more of an issue than if they're just sitting there quietly trying to keep their cool. So getting creative when trying to discern how much distress they're actually in can be really helpful. And then last but not least, of course, looking at their respiratory rate, which is going to be dependent, like I said, upon their age range. So we do have that broken up generally by 2 to 5, 6 to 12, or greater than 12 years old. Next slide, please. So this is what I just mentioned. So this is the hospital asthma severity score. And this is a score that we developed in conjunction with, we used it in conjunction with Boston Children's Hospital. And this gave us an objective way to be able to talk about our patients, right? So what looks really bad to me versus what looks really bad to Dr. Gruskin in at Children's Hospital. This gives us an objective way to say, like, this patient's a 6 or this patient's, a 12. Those numbers mean something, and they should be approximately the same to both of us, as opposed to just saying really bad. It's a tooled process that determines the level of severity. And then we have a very protocolized process to respond in to what that number is that we get based on mild, less than 7, moderate, or severe, greater than 10. We can go to the next slide, please. So this is the hospital asthma severity score system that we have protocolized at South Shore Hospital. We've depended on this for many years, and it's been incredibly helpful to standardize the care and the conversation around these patients. And I think it also helps put things into perspective so that there is clear expectations of what the next steps are, which can be especially important with these kids as well. So if you look at this, like I mentioned, the scores, which we're going to get from those 5 vitals that I mentioned earlier, we know that if someone calls us from the emergency room and says, we have a patient down here that's hossing a 12, like I mentioned, we're going to immediately get in touch with the pediatric hospitalist, and one of the neonatal or pediatric respiratory therapists will go down. And in the meantime, we anticipate that nursing already knows, because we have this protocol, that they're going to give a neb or 3 stacked nebs. We're able to use the uni-heart nebs, so we give them all at the same time. As has been mentioned, what happens sometimes is that the ED can be super crazy, especially lately. And so sometimes what we found is that, those 3 back-to-back were intended to be back-to-back, but didn't always happen that way because flow can get disrupted. So we do have a nebulizer, the uni-heart nebulizer in our ED, which allows the nurses to give all 3 back-to-back duonebs or albuterol ipratropium nebs at the same time. Concurrently, we want to make sure that they're getting their corticosteroids pretty quickly upon coming in. So we know that the quicker they get them on board, the quicker they obviously start acting. And then at the same time, we consider, dependent upon their responses to those initial interventions, a continuous albuterol bronchodilator, which that's typically when respiratory will get involved down in the ED here at South Shore Hospital. Oxygen is indicated, although oxygen can be a little bit later in the phase when it comes to asthma. So we also might consider whether or not there's something else going on. As Dr. Beatty mentioned, is it asmoniolitis, right? So there's oftentimes it's not just one straightforward thing. Heliox is something that we can use, but what's important to consider when you're thinking about Heliox, if you have it in your organization, what we use here is an 80-20 mixture. It's important to keep in mind that if the patient already has a high oxygen requirement, so anything greater than 40%, there's not going to be a benefit from applying Heliox because the laminar flow that you gain from it is washed out with anything greater than 40%. End-tidal CO2 is something that some, but not all organizations have the ability to monitor non-invasively. If you are able to monitor it, if you do have an active conscious sedation program at your institution and you have the ability to monitor end-tidal via nasal cannula, that's a great thing to be able to follow. MAG is something that obviously helps with the constriction of the blood vessels around the airways that we can consider, and terbutaline, as Dr. Beatty said, or epi. You want to make sure that you're assessing these kids very frequently and staying on top of them because they can tire or they can start responding to everything, right? Because if we go through this entire support process in this severe asthma management, we're kind of throwing the book at them, right? So they can have a great response to it. And we want to always make sure that we keep in mind that, one of the purposes of this talk today is to make sure that we feel comfortable managing these kids on our own, that there might not be the children's heroes walking through the door as soon as we get, these kids settled. So we need to think about a little bit long-term and about management. The next thing that we have here is looking at the moderate, looking at the moderate score. So if a child comes in that is hossing about 7 to 9, so that means that they probably don't have an oxygen requirement. They are definitely probably wheezing. They might be talking in broken up sentences or okay. We want to make sure that we get them those 3 back-to-back nebs. So for us, that will be in the Uniheart nebulizer. Get them started on steroids and then oxygen as needed. And again, oxygen and indication with asthma is going to be a little bit of a later thing, and we oftentimes are very suspicious of something else also going on. And then mild of 5 to 7, we're not going to worry as much about that. Those patients are probably not going to get a continuous neb. They may or may not get the 3 back-to-back to kind of break their asthma at that moment. And oftentimes, this is going to be very well associated with just some good education. We'll send them home with a home nebulizer so that they can manage this at home and teach them how to recognize the symptoms so that next time they don't end up in our ED taking up a bed and disrupting that patient and their families' lives for that. So we do a lot of education here as well. Okay, next slide, please. So this is another scoring system that we have protocolized here at South Shore Hospital that we did develop with Dr. Ellis Smith. And so this is the bronchiolytic assessment score. And so this looks at, again, a lot of the same things, but a little bit different. We look at the respiratory rate. Again, this is going to be broken down by what's appropriate for the age. So for bronchiolitis, we look at that for less than 3 months, 3 to 12 months, or 1 to 2 years. And obviously our respiratory rate is going to be expected to be different for those 3. Look at their work of breathing, again, so looking at their what accessory muscles they're using and how hard they're working. Mental status, because we're not going to be able to get a 3-month-old to sing their ABCs or tell us about their stuffed animals. So we look at whether or not they're sucking on their binky, right? We know that that's a really great thing to be able to see a baby do, that we're concerned about being respiratory distress, because that means that they still have clear nares to be able to maintain a good suction. If we're not able to get that patient to be able to take a bottle or to be able to keep their binky in their mouth, then we know that they're having some more difficulty. And we always use that as an assessment when we go down to take a look at these kids of, how do we need to intervene? And then last but not least, again, the oxygen saturation, it's important to remember that we're always going to try to do that on room air prior to starting them on oxygen. So we can really get a good sense of what they need versus what's, making them more comfortable. And so what you see here is that the way that this particular score works is that we're not adding up a number per se, but we look at what is the most severe. So even though, as you see with this example, the respiratory rate is mild, the mental status is mild, and the O2 sat is mild, the patient's having significant retraction. So we would score this patient as a moderate right now, and we would take care based on moderate protocols that we have. So it's always going to be, even if it's only one thing, It's always going to be what that one single worst assessment is. So talking about how we would care for these patients, so bringing in pediatric specific non-invasive positive pressure masks, that can be a little tricky, right? Because with pediatrics, just like with their age varies their expected norms, so does their face and interfaces that we have to use. We have to get really creative with how we provide support to these patients. And so sometimes they may tolerate blow-by for certain supports, right? But for non-invasive, it gets a little tricky. So we're lucky enough to also have a level 3 NICU here at South Shore Hospital. And so we are accustomed to using NIPV in our NICU. So providing non-invasive positive pressure ventilation may be via a RAM cannula or any other interface that you may use for CPAP in your neonatal, either level 2 or level 3 NICU. We also were able to bring in some masks that were pediatric specific that are able to cover and provide the support via the nose, and they're friendly. They have, cute little giraffe markings on them, and all of those things, even when these kids are really sick, do typically tend to make a little bit of a difference to help with their tolerance. It makes it a little less frightening, a little less cold in this really strange environment when they have a lot of adults around them. Talking about the fit of the mask is going to be important. Again, if they tolerate the RAM cannulas, if you have them in your institution, they can be super helpful because they're basically a wider bore nasal cannula that allows us to not restrict flow and provide a little bit of pressure, although not technically, when we provide either non-invasive positive pressure or CPAP or just giving a high flow. So those devices oftentimes with the different supports that Dr. Beatty talked about, so be it high flow nasal cannula, 1 to 2 per kilo, talking about CPAP or talking about BiPAP, oftentimes those same interfaces can be used for all those different delivery support systems, depending upon what you can get to fit the patient. And that could be definitely tricky in the pediatric population. We can go back for a second. I just don't know what was on that last one. Okay, tolerance, distractions. Those are really important. So talking about, again, singing to them, talking to them about their stuffed animals. If you have anything fun on your ID badge, stickers, putting stickers on, even aerosol masks or anything that you can really do to distract them from what's actually going on. They're actually going to be looking for something like that, and they can really improve their trust with you so that you can support them the way that they need it. And we here are bringing in a couple of extra vents to be able to support these patients in our pediatric ED as well as on our floor, because we too have obviously had challenges with bed flow in the region. And so we sometimes have to keep these kids here longer than expected. And so it's really important sometimes based on the severity of what's going on with the child that we determine how frequently we're going to assess these kids. We certainly have times and days when we may not leave the PDED because we have patients down there and we just need to keep a close eye on them until they kind of turn the corner. And also based on the mode of support. So it's important to make sure that people know and understand, that the nurses understand some of the things like Dr. Beatty had pointed out. Oxygenation is really supported by either high flow nasal cannula or CPAP, and non-invasive positive pressure ventilation or BiPAP is going to help not only your work of breathing, but additionally your ventilation if there's a respiratory acidosis component happening. And then we talked about both the hospital asthma severity score and the bronchiolytic assessment score, which drives our choices for the support that we provide to these patients. And if you get to the point where you're providing non-invasive positive pressure ventilation, you likely want to be following up and keeping track of how the patient's tolerating that and whether or not it's doing what you're hoping it would do by doing gases, either a VBG, a CBG, depending on the age of the patient, or an ABG. Suctioning is really important with these patients to make sure that their interfaces are actually able to work, but also being cautious about that, making sure that you're not causing swelling. So it's usually good to have a conversation about that when the frequency of that. Next slide, please. So this is just quickly our setup for our heliox. So into the non-rebreather bag that you see there, we have that in there to provide the oxygen, and then we would use the Heliox tank to be able to drive the neb there, which we would provide the continuous albuterol there. So that's if you have an asthmatic patient that does not have a high O2 need that was less than 40%. And then the neosuckers are what we use to help decrease upper airway swelling by frequent suctioning.
Thank you, Jess. I'm just one of the nurses. I work on our community of care team, and also I work with a former emergency room nurse for many years at both Boston Children's and previously at Children's Hospital of Philadelphia. All of the things I'm going to talk about could be an entire long talk or 2 or 3. So I'm just going to very briefly run over some of the things I really think you as your local teams need to consider and make a part of your planning. 1, tachypnea is an early sign of respiratory distress in pediatrics. No, next slide, Karen. It's important to know what your vital sign ranges are. Yes, we know that children breathe faster, but there's points where we don't expect them to breathe that fast. So know what your parameters are for your policy. If your hospital doesn't have a pediatric policy on vital signs, this is your cue to ask and advocate for that. And then thinking about alarm management, I have a picture here of a Philips monitor, remembering, are your alarms set for neo, PD, adult? And in that PD, it's 1 default. And as you can see, it's just an example of what we use at Boston Children's for heart rates. It's a wide discrepancy. So oftentimes you do need to go into that alarm and adjust those parameters based on your patient. Alarms only work if they are set in a way to be helpful for us. So please consider that as part of your standard practice. Next slide. And if nothing else you get from this, please know it's so important to engage the families. They're everything I love about these respiratory illnesses. I don't love respiratory illness, but I do love that it's often a time for nursing to shine. Why? Because it's supportive care, and that is what we do. We are all about that holistic whole family care. These patients are probably not going to be 100% well when they're discharged home. The family is who is going to be continuing that care and that journey. We need to, from the very start, incorporate them into our planning. So nasal suctioning, right? Keep that airway clear. It's frequent. While we have some of those deeper suctioning, the nasal suckers, inline, really thinking about even just advocating for whatever suction device that the family will use at home to be starting to use, have the family start doing that suctioning, thinking about teaching them how we need to do it before that feeding and drinking so that that child can eat and drink. Staying hydrated. And I did see a question on this that someone had put in about how much that fluid is. IV fluid is great, especially for a very ill child, and thinking about a bolus, which we know is 20 per kilo usually, and then your standard maintenance fluid calculators, again, for your standard well child who has no issues with hydration. But if we can encourage the family and empower them to do oral, that's what's going to continue to have them be successful at home. Using a syringe if you need it, set up a timer. Sometimes I set up a little tray with little medicine cups so the kids know, oh, every 10 minutes I go on the clock and I can take a little drink. Also, considering the NG-OG before IV, we know IV placement in a sick child can be a challenge, especially in those younger kids. And NG is great because it allows you to do that fluid and they can still continue to take orals. And OG is also great if they're on any of those non-invasives because you also have the ability, as Laura talked about, to decompress that belly. Looking at their urine output, teaching their parents how to do that. On the monitors, I will save you so much effort. Tell the parents what the monitors are checking. Explain it to them. Explain to them which alarms, why you aren't running in every time the monitor alarms so that they feel reassured. Again, we're partnering with them. We're bringing them in, tell them what we know, and then they will be your best advocate. And also thinking about that spot check versus continuous monitoring. We know a lot of many institutions now, especially in bronchiolitis, have moved to spot checking overnight versus having that continuous monitoring. Explain to the families when and why you're monitoring, what barometers you are. We all know those families who will just stare at that SpO2 and it goes down for a minute to 88, and then the child coughs or moves and it goes back up, but the parents saw 88, they knew under 90, and they're freaking out. If we tell them ahead of time that we expect that, if we tell them what we're looking for, you are now going to have a partner and you're going to decrease their anxiety, which is in turn going to decrease the child's anxiety because they know that that family member is who they trust. So thinking more about that and how you're educating on that. And then sick versus distress. We want to kind of, as we're going, teach and empower the families. What are the signs that yes, their child's sick versus moving into that distress? Ask for their opinion, trust their instincts. We talk about dyspnea being something challenging to monitor. The parents know their child. They may not know the term dyspnea, but they know my kid is now getting in distress. My kid is worried. And this is also going to be important for discharging home. A lot of these kids we know with bronchiolitis for particular is going to get worse sometimes before better. And sometimes we do need to send them home. They're not that sick right now. But have we been teaching them all along? What are those signs and symptoms of when to bring their child back? And to reassure them, it's okay to come back to the ER. I know sometimes we may not feel that way as providers, but to say we're always open. If you are worried, you come back. The worst thing we do is tell you that your child is fine and it's okay to go home. But we've built that trust and communication with them so that they know it's okay to come back. Next slide. And really simple, thinking about isolation. We all know your hospital's policies, but we need to explain it to families. Hand washing, but thinking about some of the stuff we have and updating on RSV and thinking about RSV with contact precautions. We're really great right now with COVID. We're all wearing kind of gloves and masks, but thinking about anyone with an unknown viral illness, just starting with contact and droplet. I know it is painful for all of us, but really thinking about, in particular in the ER, as we're moving room to room, showing the families that this is really important. And next slide. I'm going to now turn it over to our colleagues at South Coast Health, who are going to talk about some of their pearls. And again, please put in questions in the Q&A. You can reach out to us and I'm happy to share more information about those nursing considerations.
Okay, thanks, Jess. My name is Athena Exafaris. I am the Pediatric Inpatient Director at St. Luke's Hospital, which is a community hospital in New Bedford, Massachusetts, and we have a community partnership with Boston Children's. I do recognize that we are very lucky because we do have a pediatric unit, and there are a lot of participants on this call who do not have pediatric services in their hospital, but I am going to share how we approached the volume and the surge, because we were being taken care of higher volume than we were used to, and not having sort of the higher level resources as accessible as we had previously. So how we did approach that. And just to give you an idea, since August, when we start to see this surge in respiratory viruses, we've taken care of 378 patients on our pediatric units. 270 had a respiratory diagnosis, and 41 of these patients did require high flow, and 8 of those did require transfer to higher level of care, with 6 of them requiring CPAP or BiPAP. So we did definitely have to improve what we were currently already doing. Next slide. And when approaching this, we focused on the 4 S's, which I think is a good exercise that any hospital system can utilize when trying to prepare for something coming their way. And the 4 S's are thinking about staffing, thinking about space, thinking about supplies, and then systems. And in our hospital, we were looking at inpatient versus our ED care as well. Next slide. To discuss staffing is my colleague, Amanda Wentworth.
Good afternoon, guys. So my name is Amanda. I'm currently the inpatient team leader at St. Luke's Hospital. Been here for 4 years, but I started my career at South Shore Hospital and was there for 10 years before coming here. So in order to accommodate the patients that we had coming in, we needed to change what we were doing here on the unit. So the first thing we had to do was increase our staffing of nurses. So that went from 2 to 3 nurses per shift across all shifts due to the change in our average daily census. We normally sit at about 4 to 5 patients a day, and we were up to about 12 patients during this time. And one of the other things we had to do was we added an additional physician. So we added a swing shift in our emergency department. That position worked from 6P to 2A, and we were able to add about 50 additional hours during this time. That physician's role was vital because we were able to get some of our evening discharges out, which we aren't always able to do, in order to open beds to pull patients up from the emergency department. So we did not have to board patients down there. And last but not least, we have a great relationship with our respiratory therapist, but we increased the frequency of their rounding through our unit. Normally it's on more of a PRN basis. When we call them, they come in, but they are now rounding through our unit every 2 hours. And then also in the pediatric emergency department, they're rounding through there as well, working with all of the boarded patients down there.
Thank you, Amanda. So talking about space, we're trying to figure out where we're going to put this influx of patients. And so a new process for us was having to board pediatric patients in the ED, which I'm sure many of you are experiencing. So we created a ED boarding order set. So that was going to be very helpful to manage patients in the ED who are boarding there. We thought about putting PD patients outside the PD unit so that our unit was specifically just for these sicker, more respiratory patients where they'd probably get the more individualized and specialized care. So we could put 15-year-olds on the adult units, including our adult ICU, and thinking about putting infants in the postpartum or level 2 units. We buffed up our VNA services to help facilitate early discharges and to shorten our length of stays, being able to provide phototherapy at home so babies didn't have to be readmitted, thinking about sending patients home on oxygen and providing prolonged IV antibiotics at home. And then last, thinking about lateral transfers to other community hospitals that had open beds that our patients didn't necessarily need a higher level of care. The next S is supplies.
So we here at South Coast have 3 hospitals, and our St. Luke's is the only hospital that has inpatient pediatrics. So one of our biggest challenges was doing some training and getting equipment to our EDs at the other sites for high flow nasal cannula. So we were able to get them their equipment and do the education with the staff there across all 3 sites. In doing that, we obviously had to increase the amount of units, and we also had to switch the cannulas that we were using due to some supply issues. We also had to switch that with our cannulas and our low flow cannulas and non-rebreathers to be able to get these supplies. And in doing this, respiratory therapy did in-house training across the board. And they also came and did training with our pediatric nurses here on the unit to review mask and oxygen delivery, going over CPAP and things, because we were having patients stay longer here on the unit with us. So next slide.
And then the system changes that we implemented was the high flow nasal cannula weaning protocol, trying to get these patients weaned off quicker, keeping it a consistent protocol amongst all our providers. We launched the pediatric respiratory care education across all 3 of our sites, both in the ED and inpatient unit, with our pediatric nurse educator reviewing high flow nasal cannula, non-invasive ventilation, the equipment and suctioning, systems of discharging patients at different times of the day. You know, historically it'd be like after rounds and maybe in the afternoon, but now we were doing them at 6 a.m., 10 p.m., anytime the patient just like sort of hit that stable mark, we were able to get them home so we could free up a bed to admit another patient. And then also trying to figure out how we could provide higher acuity in our unit. We did a lot of training around being able to provide continuous albuterol, where historically those patients would have been transferred out to a higher level of care.
And then practice. So practice, practice, practice. So we reviewed all the equipment with staff again. We did additional training with respiratory therapy, and we had staff meetings that we added on for the nurses to go over the new pathways and also the respiratory therapists. Our physicians took part doing some skills training, which we did airway management in the OR, and also doing some IV placement skills to assist the nursing staff. We increased the amount of mock codes that we did across all shifts, and then also our simulation that we always offer.
And when it's time to push for transfer. So we are a pediatric unit, but we do recognize that sometimes the care will exceed our local resources and the patients continue to worsen. And so some pre-transfer considerations is we've made sure we've maximized hydration, suctioning, getting that blood gas just to see where we are on that continuum. Do I have, you know, a half hour, or does it look like I have a couple hours, sort of giving us that piece of data. And also the chest x-ray, when patients are worsening, you know, will that provide some additional information? So considering that as well. And then when it's time to transfer, it's time to call in some help. And so the transfer line number is here. This helps in determining whether there is a bed available and is it appropriate, what is the most optimal mode for transportation, and then ultimately some guidance in management while awaiting for transport. And a Boston Children's Hospital intensivist is available on this advice line, which is extremely helpful. And that's it. So I guess questions.
Thank you so much to absolutely everybody. That was an amazing amount of content. And I do want to acknowledge that last bullet that you made. The Boston Children's Hospital intensivists have just been heroic in the support of care for children who have been awaiting transfer. It's an extraordinary resource and they definitely deserve to be well recognized for that. I apologize. It looks like we're about 2 minutes past time, so we're not going to be able to do questions right now, but we have taken note of the questions that were submitted to us. We'll try and get you answers back. Again, as a reminder, these slides and this presentation will be posted on rdhrs.org for you to view again if you want to come back to this or to share with colleagues if you think this might be useful to them. I really want to thank our speakers, obviously extraordinary experts in what they do and the perspective they share. Thank you to all of you. We have one more session scheduled next week. We look forward to joining you then. And as Dr. Gruskin said, as all of us, thank you so much for what you're doing right now and have been doing through this surge. It's extraordinary and unfortunately very necessary. All right, take care.